Welcome back to Neutralizing COVID, the monoclonal antibody story, the podcast where we unpack the science, strategy, and real world impact of monoclonal antibodies in the fight against COVID 19. I'm your host, Dr. Shikha Agrawal. Today, we are debating delivery methods and their influence on effectiveness in the delivery debate, how route affects antibody impact. I'm pleased to have Dr. Aiswarya Chaudhuri, a nanomedicine researcher, here again as we explore today's discussion. Welcome to the show, Dr. Aiswarya.
Thank you, Dr. Shikha. It's an honor to be here again. Let's decode what's really happening here.
So, to start us off, what are the main delivery routes we are talking about when it comes to COVID monoclonal antibodies?
Primarily, there are three routes. The intravenous, where the antibody is delivered directly into a vein. Second is the intramuscular, injected into the muscle tissue. And third is the subcutaneous, injected just under the skin. Each route has different implications for how quickly and how well the antibody reaches the circulation.
Let's begin with IV. That was the earliest method used during the pandemic, right?
Yes, IV infusion was the first route used for the COVID monoclonal antibodies. It allows for rapid and complete bioavailability, meaning nearly all of the antibody dose enters the bloodstream right away. That is especially useful when time is critical, like when trying to reduce the viral replication early in the infection.
But it's more logistically demanding, correct?
Exactly. IV infusions require clinical settings, trained staff, and observation time after administration. That limited the accessibility, especially in areas without infusion centers or in emergency settings with high patient loads.
Okay, then came intramuscular delivery. What changed with that approach?
Intramuscular injections offered a more practical alternative. Some monoclonal antibodies were reformulated or engineered to be effective when given by INs intramuscular. The big advantage is that they can be delivered in outpatient clinics, pharmacies, and even mobile units. That improved reach and reduced the staffing burdens.
On a related note, were there any trade-offs with intramuscular delivery?
There can be. IM absorption is slower than IV, and the total bioavailability may be slightly lower. But certain monoclonal antibodies are designed to be potent enough that this didn't compromise their ability to neutralize the virus, especially in the early or the preventive cases.
And what about subcutaneous injections?
Uh, SC or the subcutaneous injections were explored for some antibodies, especially for the prophylaxis. Like intramuscular, subcutaneous is minimally invasive and does not require infusion equipment. However, it often requires a larger volume or multiple injection because monoclonal antibodies are big molecules. So subcutaneous also tends to have slower absorption than intramuscular.
Dr. Aishwarya, you have set that up nicely. Next, I would like to ask, how did researchers decide which route to use?
Several factors came into play, like urgency of treatment, available infrastructure, patient population, pharmacokinetics, means how the drug moves and acts in the body. In some cases, the same antibody was authorized for more than one route depending on the situation. That flexibility was key during variant surges and resource bottlenecks.
So it wasn't about one route being best, but about matching the delivery method to the need.
Exactly. IV was great when you needed fast action and had the infrastructure. IAM and SC made it possible to reach more people faster. The ability to adapt the delivery routes was part of what made monoclonal antibody strategies viable during changing phases of the pandemic.
Were there any notable changes with switching routes?
Yes, reformulating a product for a new delivery method isn't trivial. It requires new clinical trials, stability studies, and regulatory review. Also, the immune response to injection, local reactions, or variability in absorption can differ by route, which needs careful evaluation.
Were patients given a choice in route, or was it provider driven?
Typically, it was based on availability and logistics. During peak waves, providers used what was on their hand and what their facility could support. The priority was getting treatment to people as efficiently and safely as possible.
Looking at the future, do you think the experience with different delivery routes will shape how we use antibodies going forward?
Absolutely. We now have proof of concept that the monoclonal antibodies can be adapted for more stable delivery. That's important for the future pandemics, but also for conditions like RSV or flu, where rapid and wide deployment of antibody-based preventives could be a game changing.
Before we close, what's your main takeaway for listeners when thinking about how delivery methods shape the role of monoclonal antibodies in COVID 19?
That delivery isn't such a technical detail, it's a part of the strategy. The ability to pivot between IV, IM, and SC gave monoclonal antibodies more reach and relevance. It turned a lab innovation into a real world tool.
Thank you, Dr. Aishwarya. That was a clear and really helpful breakdown of how delivery routes mattered, not just in theory, but in practice.
Thanks for having me. Truly enjoyed it.
That's it for today's episode of Neutralizing COVID, the monoclonal antibody story. Huge thanks for listening. Be sure to follow the show and share this episode with someone who loves staying curious. Until next time, take care and keep exploring science.